Hello and welcome to the Clinical Care Options Infectious Disease podcast. I'm your host, Zachary Schwartz. Today we discuss the fundamentals of how to identify refractory CMV infection after solid organ transplantation. I'm delighted to be joined by Dr. Camille Kotton from Harvard Medical School. To follow along with the slides, visit the show notes for this episode. Now let's get started.
I'm going to talk about identifying and understanding refractory CMV infections in transplant settings. So as you know, CMV is the most common infection after solid organ transplantation. After primary infection, CMV is usually latent in humans unless they are immunosuppressed or pregnant. Roughly half of all adults in many European countries, the US and Canada, Australia, of all of those adults, about 50% are CMV positive. It is higher in other regions. So if you're practicing in Brazil or Italy or India, there are higher rates of positivity in CMV for CMV IgG positive adults. There are good but not perfect options for prevention and treatment after transplant and what causes a spectrum of disease. Resistant refractory disease adds complexity, and I think that's why many of you are here today, and really adds a burden to how we manage these patients. So there are the direct effects of CMV, which is really what infection looks like. And that ranges from asymptomatic CMV to CMV syndrome, which includes fever and malaise, all the way to CMV disease, where there's gastrointestinal disease, pneumonitis, et cetera. We can significantly decrease rates of direct CMV, the direct effects, or significantly decrease rates of CMV infection through preemptive therapy and monitoring, antiviral prophylaxis, if there's prior immunity, CMV immunoglobulins, vaccines, monoclonal antibodies, and cellular therapies are all things that are in development. And then the more immunocompromised they are, or if prophylaxis has ended, or if they have de novo, or what we sometimes call community exposure, those can all be unexpected areas where we see higher rates of CMV. Or not necessarily unexpected, but higher rates of CMV. And then there are the kind of evil specter of the indirect effects of CMV, where we see higher rates of all types of infection, higher rates of PTLD, higher rates of cardiovascular events, new onset diabetes after transplant, immunosenescence is altered, acute rejection and mortality occur at higher rates. In other words, CMV is bad, right? Then there are indirect effects on the individual organs. We often think that if you really want to enhance outcomes for your individual patient as well as your overall program, the best way to do it is to really prevent CMV as best you can. There's some really interesting data that was just recently published from British Columbia, and they looked at the impact of prior immunity, the magnitude and duration of the viral load here. D plus, R plus, it's like not really that bad, right? Not such a high magnitude of CMV, and in general, it's cleared and whatnot, so probably lower indirect effects, but it's the D plus, so donor positive, recipient negative group, really a pretty significant magnitude and duration of CMV. That's a brilliant paper if anyone wants to read about CMV kinetics. So treatment of CMV after transplant is overall pretty straightforward until we just published the 4th International Guidelines on CMV management, and so this is adapted from that. The first step is determining the severity of infection, and for the vast majority of people, it's fine to give, if they have mild to moderate CMV, to treat them with oral valganciclovir, renally adjusted dosing. That's pretty straightforward. I would say that's 90% of what I do is oral valganciclovir treatment as an outpatient. But for people with severe CMV infection, ophthalmologic disease, retinitis, colitis, if there's severe GI malabsorption concerns, or if there's resistant refractory disease or life-threatening disease, so sight-threatening, life-threatening disease, I usually admit them to hospital. Also, if they have a DNAemia somewhere over 100,000 IU per mil, I usually admit to hospital for intravenous ganciclovir. And then for almost everybody, it's a time to think about, could they be on lower immunosuppression? Do they have hypogammaglobulinemia? Do they need their immunoglobulins replaced? That type of thing. The treatment of CMV after transplant also includes checking a weekly CMV DNAemia on plasma or whole blood. And in the guidelines, we said that antiviral treatment should be continued for a minimum of 2 weeks until clinical resolution of disease and a decrease in CMV DNAemia below the institutional laboratory-specific threshold, which was per grade, a strong and moderate recommendation. And so this might be below the lower level of quantification on a single sample with a highly sensitive assay, or 2 consecutive weekly samples with less sensitive assays. And One thing that we have thought a lot about is you don't really have to drive this down to zero. Like, it's really getting it, say, below a certain institutional threshold that might be below 200 IU per mil. But I see a lot of people who are trying to, with a very low 78 IU per mil, very low numbers, and they're trying to drive it to zero. And that probably is not necessary. So you don't have to completely ablate it. You just have to have it very low. But importantly, if the DNAemia doesn't fall after 2 to 3 weeks of appropriately dosed treatment, or if the clinical status isn't improving, then you really start to think about, is this resistant refractory disease, and do I need to send resistance testing? There's an important pearl, which has been in all of the guidelines, but basically many people, when you start treatment of CMV, they often go up at week 1. And so you'll see a DNAemia that can increase at week 1. And for me, that's where that concept of DNAemia is helpful, because it just means you have potentially more CMV fragments that you're amplifying. So it may increase at week 1, but hopefully by week 2, you should see a significant downward trend. So what are the risk factors for difficult to treat or resistant refractory CMV? So the number one risk factor is when the donor is seropositive and there's a seronegative non-immune recipient. That is the number one risk factor. Also, if there's increased immunosuppression or older transplant recipients who have perhaps no prior CMV immunity or waning herpes virus cellular immunity. Also, the use of belatacept. When there's a D plus R minus situation and patients are on belatacept, for me, that has been one of the top risk factors for developing very challenging to manage CMV. So I usually say, can we get them off the belatacept at least until we can clear the CMV? Also, people who've had longer exposures to antivirals, or if there's a very high DNAemia at the time of antiviral initiation or during treatment. And then antiviral underdosing or mini dosing is something that we really recommend avoiding, because underdosing of antiviral medications is kind of one of the top ways to breed resistance. It's really important to know the patient's kidney function and make sure you're accurately dosing. I think many people end up overdosing valganciclovir, and so then they get some toxicity. So it's important to dose correctly. So not overdose, not underdose, just hit right on the target. And I actually spend a lot of time talking to my nephrologists about what is this patient's true renal function. And that's often very helpful. And then you often have to keep adjusting for the valganciclovir. Also, it depends which organ is being transplanted, but certainly lung, intestinal, and composite tissue transplants have the highest rates of resistant refractory CMV. So we had new definitions that were published this past year for resistant refractory CMV. So refractory CMV infection, so this is like the first step, right? Recognizing that something's not going well, refractory disease, is defined as when there's CMV viremia, DNAemia or antigenemia that increases at least 1 log in the same blood compartment, or if it just persists. So it stays, either increases a log or stays the same after 2 weeks of appropriately dosed antiviral therapy. And again, I can't stress how important it is to make sure your antiviral medication is appropriately dosed. Refractory end organ disease is when there's a worsening in signs and symptoms or progression to end organ disease, or a lack of improvement in signs and symptoms after at least 2 weeks of appropriately dosed antiviral therapy. Usually we're not seeing so much end organ disease these days. We're more in the usually just infection and just looking at the patient's signs and symptoms, but often their DNAemia levels. I will say that these guidelines were specifically developed for clinical trials, but in some ways the thought around them can reflect what we are doing in clinical practice. Resistant CMV infection is where they have refractory CMV, so not improving CMV or worsening CMV, plus the presence of a known viral genetic mutation that decreases the susceptibility to one or more anti-CMV medications. Resistance testing. So there are 2 types of resistance testing out there that are commonly used. The Sanger sequencing method is what had been used for a long, long time, and this is quite good. It detects variants down to about 20%. Overall, very good and accurate, but does miss some of them. Next generation sequencing can detect mutations at a 5 to 15% variant concentration, so is more sensitive than the Sanger method. We recently, about 3 years ago, switched from Sanger to NGS by switching different commercial laboratories. Before, or if you don't have access to CMV genotyping, we recommend following the algorithm that we will be showing you from the guidelines with presumptions as to the best choices to make. And just be aware that if you need to have a certain DNA EMEA, usually at least 1,000 IU per mil, to get good sequencing results. The drug resistance testing is actually quite expensive, somewhere in the range of a few $1,000s often. So don't send it if it's 284, because it's not going to work and you will have spent the money. I always try to do good stewardship. The burden of refractory resistant CMV is quite significant. CMV is pretty easy, except for those few patients with resistant refractory disease, and they really can take up a lot of our time, and these patients really suffer. We think that overall the rates of refractory resistant disease are generally quite low, but have been reported in somewhere from 2% up to 12%. I think if you do have higher rates of refractory resistant CMV, you might want to review your protocols. I do have a lot of people that contact me that are they're using mini dosing of valganciclovir or too short of prophylaxis or whatnot. There are areas where sometimes we can tweak things so you have lower rates overall. These folks have higher rates of hospitalizations, more complex care. They have increased risk of graft loss and rejection, higher rates of morbidity and mortality, and overall increased cost. And Dr. Humar will talk about that, but the medications, hospitalizations, clinic visits, and testing really all add up.
Well, thank you, Dr. Kotton, and many thanks to our listeners for joining us. To learn more about how to navigate complex refractory CMV cases in solid organ transplant, click the link in the show notes. And to get access to all of our podcasts, subscribe to the CCO Infectious Disease podcast on your favorite player. Thank you, and we'll see you on the next podcast soon.